All right, class, we're going to continue on with the acute care of our chronic patients. And now we're going to talk about the specific things that you might see out there in the field and things that you, again, how to handle these different situations that you get. So home care oxygen delivery devices, respiratory devices, there's all kinds of them out there. Again, and COPDers, again, they have all kinds of, these are your emphysema, chronic bronchitis, and asthma patients, and they can have all three of them actually. So usually with the home equipment fails, they often panic, and usually a simple treatment is turn the oxygen up a little bit, okay? So again, remember, we've gone over this a lot, but the big reason that we get called is for your, usually because the equipment fails, and it's usually the breathe-in treatment. Hey, newsflash, we got those, we're good, okay? We can actually start giving them a breathe-in treatment. As far as leaving them at home, I would say if it was bad enough to call me and you don't have the kit to fix it, then you probably need to go to the hospital so that we can get replacements, and more importantly, make sure that your condition is stabilized, because they usually don't wait. They usually wait until they get into trouble, and that's when they call us, okay? CHF patients usually present with the respiratory problems. Usually they have the pulmonary edema. And the cystic fibrosis, remember that this is a genetic disorder where it's overproduction of mucus, and again, it inflames the small airways, and then it causes chronic infections, and then once they get sick, again, by the way, we've got CFers now living into the ages of actually 50, 60 now. But the biggest problem is that they start coughing a lot, and then they start spitting up blood because of it, okay? Or they pop a lung because of it. And the cystic fibrosis doesn't help there, because that fibrous tissue actually ends up ripping and tearing when they do that. So again, severe fatal pulmonary hemorrhage can occur sometimes with this, and they usually suffer from right ventricular failure or hypertrophy, and they got pulmonary hypertension along with it. Again, because they try to pressurize the blood flow through their lungs. That's why they end up doing that. Your bronchopulmonary dysplasia, these are usually with your infants of low birth weight. They're usually on a mechanical ventilation for respiratory distress. And again, usually they have a lot of pulmonary congestion, and they'll put them on breathing little CPAPs or actually home ventilator equipment. You very rarely actually kind of see this in the field, but again, the biggest thing is, again, make sure you got adequate ventilatory support for these kids, and take them to a neonatal facility. Take them where they got a NICU. All right. Again, neuromuscular degenerative diseases, your myasthenia gravis, your muscular dystrophies. These, again, usually they break down, and the problem is that it starts to break down. They go into respiratory failure. They get a lot of accidental injuries because of this. They usually don't live past their teenage years for the muscular dystrophy kids. Poliomyelitis, again, this is a very, very rarely seen nowadays. Again, lots of vaccines for this. You just don't see it. But when they do, there's no systemic effects, but it actually paralyzes the motor neurons, is what it actually does. They can't actually breathe. The old polio patients would actually be in an iron lung, and an iron lung basically created negative pressure so that you would suck air in, and then it would increase the pressure to push air out. Okay. Guillain-Barré syndrome. You guys know that I love this one. This is an autoimmune response to the viral infections, and what it usually does is it causes weakness and then muscle paralysis because the nerves demyelinate. Okay, and again, they usually, of course, this paralyzes the respiratory tract, which supported ventilatory care. They can actually recover from this pretty well. Okay, myasthenia gravis. These guys, it affects the neural junction, which then causes muscle weakness. But the muscle weakness gets to the point where they can't actually use their respiratory muscles, and that's what they usually end up dying from. And again, intubation and artificial ventilation is usually how we treat those folks, especially in the acute setting. The sleep apnea, these guys, these are the kids that are usually on some sort of monitor. They just essentially, the lack of respiratory drive from all the relaxation. Okay, a lot of us are on CPAP at home for this, and again, usually the way that you treat that is they can actually implant things that kind of reminds you to have your tongue not fall back in the back of your throat. So again, you want to avoid using CNS depressants or alcohol, because this only makes the snoring worse. Okay, lung transplants, again, when they get a lot of pulmonary fibrosis or their lungs are really shot, and then traditional therapies are going to be ineffective. They'll actually do a double lung transplant for these folks. So your home oxygen therapy, again, we're usually pretty versed with oxygen. All right, we know how to deal it. But one little side note: usually the home oxygens only go up to 6 liters a minute. Okay. News flash: we carry a portable tank that'll go up to 25. There you go. One of the biggest reasons we get called out is when the power fails. Okay, they should have backup sources of oxygen. If you're prepping for a storm, make sure that they have plenty of oxygen on hand. Especially when you get maybe 10 or 12 days after a storm, they usually don't plot out that long. So again, they usually get like 1 or 2 days, and usually these folks are in a rural setting. No, they need a little bit more oxygen than that, okay? Again, they get stressed because of the storm, they start using more oxygen, and they burn through their supplies. And they don't have any power to let their oxygen concentrator actually do that. By the way, there's the 3 things here. The liquid oxygen, I don't hardly see these at home. I guess there would be some places that you might see that. But the oxygen concentrators are the 2 big ones that we see out there, okay? Safety tips, we're not going to go through those. Again, keep it away from fire. Trachs. These guys, small surgical openings. Again, they're temporary or permanent, but usually there's a stoma there. There's an outer cannula and an inner cannula. And the biggest thing is that they got to keep the stoma clean and dry. If not, you get germs in there. You get a lot of mucus production, and it requires a lot of frequent suctioning. You guys have all gone to ICU and done that lovely stuff, getting all that lung butter up through those little tubes there. Yuck, yuck, yuck. But again, make sure that the tube is clean. We can use our soft tip suctions to do that, or we can use, actually, I've had to use a Yankar before to actually suction. Remember, 10 seconds or less if you can. You got to get the tube. If you got a loose fitting or disconnected tube, again, fix that. Again, and again, we can't actually do a trach insertion. Newsflash, we can. It's not that hard, okay? If you've got the stoma there. But again, make sure that it's a tube that we can actually use it. And again, if there's a problem, you need to transport immediately. If it's not like in-your-face problem and you can't figure it out, take them to the hospital where they can actually perform good trach care. Okay, usually your bag will connect right into the trach. It has a 15 to 22 millimeter adapter there, so it's usually not a problem. If the airway is the problem, you can clear it. Again, suction is your friend here. And then this is a standard stoma. And by the way, this usually goes into the trachea, so if you need to put a tube in there, size 6 usually works pretty good. Insert just past where it gets past the hole, inflate your cuff, check your breath sounds just like you normally would. All right. Again, if you're unable to ventilate, make sure you get everything cleared. If the cuff first deflate, if it's cuffed, make sure you deflate it. Insert, if necessary, you can insert the tube into the stoma, and then secure the airway, and then proceed with your assessment. Again, nothing has changed. If you've got an airway problem, fix the airway problem. Okay. Again, home ventilators, they're actually becoming a little bit more if they got spinal cord injuries, muscular dystrophies, again, polios, Guillain-Barrés, they're using home ventilators at home for these guys, okay? And so they provide positive pressure ventilation. We've already gone over ventilators, so I'm not really going to go. But again, it's really simple. Breaths per minute, tidal volume. What's making the chest go up and down? Tidal volume goes up till you see the chest go up and down, okay? You want to gauge from around 8 to 10 breaths per minute. Yes, there are fancier settings on these, but again, do you really need the fancier settings? When it boils down to it, breaths per minute, tidal volume. Did you see the chest go up? Okay. Again, then these are good tools on every ventilator when you do that. All right. CPAP, BiPAP, I think we're all good. The difference between the BiPAP, again, is you got one pressure going in and a release pressure that's a little bit less, okay? And by the way, patients that use higher levels of pressure than CPAP, they'll put them on BiPAP. Again, you can put more pressure in, less pressure on the way out, okay? But it still holds those alveoli. That's the key thing there, is the CPAP and BiPAP hold the alveoli open. It helps recruit alveoli. It helps the difficulty breathing patient get better. The more air sacs we have open and exchanging gas, the more gas exchange you get, and usually the faster and better the patient gets. Okay? So again, if the home ventilator fails, by the way, immediately go for your BVM. Period. Okay? Again, if the equipment fails, that's part of your dope mnemonic, right? If they fail, make sure that you start ventilating the patient. All right. LVADs or ventricular assist or vascular access devices. They're usually provided for long-term treatments. They can be single, double, or triple catheters. PICC lines. These guys are inserted in the AC usually, and then it dumps right out next to the right ventricle. So that is the PICC line. If it rips, gang, yeah, that's a problem because you got basically a gigantic embolus in there. If it is torn or anything like that, you want to make sure we don't pull these out usually. But again, they're usually sutured in. By the way, the PICC lines are usually sutured in, but they do have a disconnect down here at this general end. It can be clamped in case of you don't want to have an air embolism going into that area as well. If it tears, again, you want to clamp it before it gets to the skin, if at all possible. They're usually surgically implanted devices, by the way. The portacasts, we are not allowed to access those unless you have very specific training. You will not be receiving that training here, okay? Again, infusion ports are usually below the skin, but look for these things. Again, these are excellent sources for med administration, assuming that we have access to the ports, okay? Dialysis shunts, these are usually, there's a fastener, there's a connection site where they'll actually stick the shunt instead of sticking this. Usually they have some sort of bandage over the top, or it could be implanted up underneath the skin. All right, so these are used to, again, accessed in order to do dialysis, hemodialysis. Anticoagulant therapy, you'll use a VABs on anticoagulant therapy. Usually any type of shunt has high amounts of heparin. So if you were to use the venous site of that side for the shunt, you need to make sure that you withdraw all the heparin. Don't start just flowing fluid into the venous side of that, because then at that point you're going to be pushing a very large amount of heparin into their system. Usually the standard withdrawal is 100 cc's of blood before we start 100 cc's of fluid with the heparin therapy in it, and before we start administering it. Okay, I would definitely consult med control before I did that. There's going to be times when they have a vascular access device that we will need to access. We just need to make sure that we access the right things and make sure that you pull the heparin out. And always, and I repeat, always call to make sure that that is okay. All right. Again, signs and symptoms of an air embolus. Again, headache, shortness of breath. If they get air in these lines, it breaks and they're getting air in there, bad thing. If we get too much in there, eventually they're going to end up dying on you, okay? So the other complications is you can get an infection or hemorrhage. Again, these are kind of common, especially for your central line catheters. Again, and they become septic more quickly, and especially if they have a weakened or immunosuppressed system, which, by the way, these people usually have multiple other things than which they have wrong with them. Okay, let's see here. Cardiac conditions, again, they have all kinds of stuff at home. Again, the bedside cardiac monitors, Holter monitors, these are kind of a normal thing. Again, they'll monitor them at the house. I know if it's me, I don't want to stay in the hospital. Quite frankly, you can finish with my cath, and I've got a life pack at the house. I'm good. Let's go to the house, okay? I still haven't sold my doctor on that yet, though, by the way. GIDU crisis, again, the urinary tract dysfunctions. Again, external devices are usually known as the Texas cath, which are coming a lot more. They also have a suction device for the females now, where they'll actually put it on top of the urethra on a female and have a low-grade suction, and then they actually use that to help collect the urine so that they don't have to Foley. Foleys are kind of becoming out of vogue, and it's just because of the definite because of the infection. You have a lot of infection. So there's an example of a Texas a bag, and then of course this is the example of a Foley catheter. So they've inserted it through the urethra that gets up into the bladder. The balloon blows up. So when they yank this thing out, yeah, they yank that. They giving themselves basically a stent move, all through that the urethral sites. And ow, I guess that hurts. They can actually put in suprapubic catheters. So back to that one there, they can actually go in up top here, and they can go straight into this area. That's usually a surgical procedure when they do this. And again, they can actually have urostomies in there, where there's a hole in the abdominal wall in order to drain the urine. Okay, and usually, again, the biggest thing is these guys get infected. They usually start giving a tea-colored or a bloody tinged when they got urine in there, and then again, and it's usually they've got particulate in there, nasty, junky, really thick, usually mostly discolored, little white things growing in it. Ugh. Okay. NG tubes, again, this usually decompresses the decompressed gastric contents in the pre-hospital environment, and we can lavage this. Okay, so yes, we were trained on first semester how to do NG tubes. Again, simply do it, pull it back, make sure we're getting the gastric contents out of it. Then it is open for us to give PO meds down. Okay, then feeding tubes is a little bit harder, which usually they're either G tubes, which go into the duodenum, or J tubes that go into the jejunum. Again, so it kind of depends on where it's inserted, but usually they'll have a feeding pump. But biggest thing here, make sure the feeding pump's in the right place. I've seen people, it's amazing how we can put an NG tube in the trachea, and then they will pump it full of, it's not in the right place. They'll pump it full of feeding fluid straight into the lungs. I will tell you that most of the time that's usually synonymous with death when they do something like that, okay? So make sure before you start your feeding, make sure the tube's in the right hole, okay? Again, listen over the gut. Make sure that you've got, when you push the saline, the normal saline or sterile water in there, that you've got nice, you can hear it in the gut, okay? It's an unmistakable sound. It doesn't sound anything like it's in the lungs, okay? Lungs, guys, are up here, stomach down here, okay? Up here, lungs, even at the bases, maybe right here, down here, stomach, okay? Colostomies, by the way, they're usually a surgical implant. They can have them pretty much anywhere. Again, they can actually have them up top. They can have it across. The most of the ones that I see are down here, usually in the left lower quadrant is where they will put them usually. Okay, but they can be on either side, by the way. It kind of depends on the surgeon, the situation. Okay, and by the way, they're usually self-conscious about their conditions, especially with that. So they probably won't, they're not really keen on answering questions. Make sure you do that in private. But the biggest, again, acute infections where they have an infected area, and sometimes they can actually be gauze packed, or they'll have drain tubes in there. And again, they do close up. And be aware that if you got improper wound healing, you're going to have to transport these folks, because they're probably going to have to cut it open, re-clean it, repack it. Surgically debride it, okay? This is a normal thing that's going to happen, okay? So inspect the wound and use sterile technique in a redress appropriately, all right? So your postpartum and newborn cares, again, no need to go over that. We've done these, guys. Again, this is just a rehash of again, by the way, what they are talking about, though, is when you do a home birth, and yes, these are becoming more and more popular. Guys, usually everything's great, everything's wonderful until it goes wrong, and then when it goes wrong, that's when things get kind of hairy, okay? And, of course, they don't call us because everything's going right. They're calling us because they delivered the baby and something's horribly wrong, usually, okay? Again, standard emergency call there. Again, you might have a doula there at the house, or a home health surrogate, a midwife there. Again, but again, we treat them like any other healthcare professional. But at that point, they've called for us. Now it's our baby, literally. Okay. Hospice care. Again, these are people I would actually very much listen to. Again, usually they don't call us until most of the time the patient's dead. And they're very specific about that. Because again, they do a lot of palliative care, managing the pain, relieving the symptoms. That is their expertise, and they're darn good at it, okay? But my point is that they, again, when they're calling you, something is usually super bad. Or part two, we're usually called because a family member panics, okay? They're watching their family member die. Even though they might have been prepared for it, they weren't prepared for what they're about to see next. They then, a lot of times, they'll want to rescind DNRs, and if they have the power of attorney, unfortunately, they have the right in which to do that, okay? Again, include your hospice peeps in this. They are extremely good at handling these situations, okay? But go off of what they're telling us to do, by the way, I think is a very good rule of thumb to handle these situations with hospice care, okay? Guys, they very much do coach about end of life, that you call everybody else before you call hospice, you call everybody else, and then you call for EMS, because they don't want us to intervene. They basically want us to come there and do the pronouncing. And essentially, again, that's probably all we should be doing when these folks have a valid DNR order. And again, they are extremely versed on getting these things, okay? They know the process a whole lot better than we do, okay? Again, but by the way, we also get hospice care is not only for cancer, by the way. It's for any end-stage disease, okay? End-stage disease is the key thing that they're probably going to be in there. And again, just remember, these guys are experts in dealing with the grief situation, okay? And when I say experts, they're extremely, I don't know how they do it. Honestly, I don't, okay? Again, our dealings in healthcare is always, we're there to save somebody's life. And again, it's a very hard paradigm for me to kind of shake. These folks there are, let's let them pass with dignity and pain-free. And they're extremely good. Again, I can't stress enough. They're extremely good at what they do, okay? And they prepare the family for these, all right? They very much do, all right? But sometimes we get called to those situations. Just understand and relate that sometimes that we have to do that, okay? Unfortunately, we kind of get caught up in that 21st century medicine of taking care of people, okay? Again, understand that we're working, go to the experts, whoever was there, go to those folks and say, hey, what's wrong now? What is the issue with this? And simply asking the question, how can we help? It's amazing how far, sometimes it might be, hey, we just need to get them to the hospital and clear out their airway. That might be as simple as it gets, gang. So again, understand that once you're going to a call with this nature. And fortunately, it is becoming more prominent that we do that. But I will tell you, early intervention in these folks usually saves us from a lot of CPR, okay? So how about let's do the stuff early so that we don't have to do a lot of work later, okay? That's it for this one, and I'll see you guys on the next one. Take care.